I just wanted to tell you this is an effort to bring a venue every other month of hot topics in geriatrics and palliative care. Sometimes it's going to be more geriatrics. Sometimes maybe with more palliative care. Right now it's going to be led by Dr. Espinosa and myself. And the idea is to bring things that are really current to healthcare and issues that are cutting edge, that are controversial, that are, that we have potentially an impact. And today, with the support also and advice of Dr. Lichtenstein, we choose a couple of articles to just frame the conversation. It's not a journal club, so we wanted to hear from all disciplines and your current experience. And we choose an article that was published in JAMA fairly recent in February, that is actually a core of the issue of healthcare reform. So the way that we wanted to do this today is, let us start with a little bit overview. So Dr. Sandra Espinosa will do a little overview of both articles, especially the end-of-life one, and a little bit about what the geriatrician's role is. And then I will start asking, some hopefully provoking questions. Simple rules, all opinions, even if they are different, are welcome. And if we get really excited about something, just let each other finish. And I think the other rule is don't take anything personal. Let's just make it about, and especially for our fellows graduating pretty soon, this is just on target. Okay, so Dr. Espinosa.
So this article actually was suggested by Dr. Lichtenstein, who unfortunately couldn't be here today because I think he's out of town. But it's a pretty timely article. It's basically looking at patterns of end-of-life care since from 2000 to 2009, so over the last decade or so. And in case you all didn't have a chance to look at it before you got here, I'm just going to briefly go through the main points. But basically this study was conducted because other studies had reported that there's an increase in people dying at home and less prevalence of people dying in the hospital or in institutionalized settings. So they wanted to really conduct a study to look at patterns of where people are dying and use of services around the time of death in actually Medicare beneficiaries. Well, that's how they conducted this study. So very briefly, they did a random sample of 20%, random 20% sample of all fee-for-service Medicare beneficiaries who died in 2000, 2005, and 2009. And the patients had to be 66 years or older at the time of death. And then they use statistics, basically descriptive statistics, to look at their socio-demographics, their diagnoses, and where they died, how many healthcare transitions they had prior to death, etc. So again, this is not a journal club, so we're not going to really go into huge detail. But just I want to point out the major results, and so just descriptively, the sample was about 82 years of age, majority, about 58% were female, and 88% were white, which is something to consider because we do a heavily Hispanic patient population here. They did state that over time more Medicare beneficiaries did die in locations other than home, acute care hospital, and nursing home. So just getting into the details, they did find that use of hospice services at the time of death increased from 21% in 2000 to 42% in 2009. But short stays in hospice primarily increased. So I can't remember how they described it as a short stay, but 3 days or less. So hospice use of 3 days or less increased from 22% in 2000 to 28%. And of the late hospice referrals, meaning getting hospice in last few days of life, 40% of those patients had been in an intensive care unit setting within that immediate time prior to death. So in 2009, more patients than in 2000 had an ICU stay within the last month of life. And also, in addition to that, nursing home admissions also increased in the last 90 days of life, slightly. In addition to, okay, so we're saying shorter hospice stays, more ICU utilization in the last few months of, or last month of life. They also found higher rates of transitions. So in 2000, the mean rate of transitions near the end of life were 2.1% per patient. That increased to 3.1% over that 9-year period. So about one additional, well, not about, one additional transition. And they call it, they also characterized what they called burdensome transitions, which were transitions that occurred in the last 3 days of life. And these also increased. Let's see what else. Those are the major findings. So basically their conclusions from this study were that, sorry, let me get to that part. Although there was an increase in hospice care that was then previously reported, there were also increased use of ICU care, increased hospitalizations in the last 90 days of life, increased transitions. And they suggest in their comments that that increasing hospice use may not actually lead to a reduction in resource utilization, and perhaps short hospice stays are being used as sort of an add-on to a growing pattern of more utilization, not less utilization. So that's the take-home point from this study.
Very good, thank you, Dr. Espinosa. So why I wanted to open it. We have more than ever these challenges, right? People using more aggressive therapies. Why? Why do you think that's happening in your experiences so far as fellows and faculty? Why people are getting more aggressive therapies when they shouldn't?
Because, from the past, medicine has been working as if we are sick, we go to the hospital, we get better. So even nowadays, that is, I think, the thing that, if you are sick, you have to go to the hospital, and then you will get better. And then that's why, and then we continue to offer them more treatments, so that's why I guess patients spend more time in the ICU nowadays, or, last days in the hospitals, because they have that thing in their head that, I'm here in the hospital and I'm going to get better. So, whatever you have to offer to make me get better, I would need that. I would agree or accept that. So I guess that's why.
That could be a very good, what else?
It seems that there's a shocking denial of that just pervades our culture. Even when somebody knows that they're dying, they still are in denial that they're dying. Or it's odd that we get people in palliative care, and then when they get right to the very end, they reverse everything because, I don't know, if they think there's going to be some, miracle cure-all or something that's going to happen. And there's something about the way that we handle and manage death, I think, that has a lot to do with that.
Can you expand on that? What do you mean by that?
It's not natural. It's the way, maybe on the reverse, how we went from medicalized childbirth, and then we went to something unmedicalized. It's sort of like a pendulum swing thing where, so people were having babies at home for a while, and then because a few people died in that process, it got taken away from being able to have a baby at home. Now you have to go someplace so that you can't die in childbirth. Well, it seems like on the other end, it's the same thing. You're not allowed to just die naturally, for anything. There has to be a cure for stuff. So,
Fascinating.
Litigation.
Another big issue, right? So, what do you guys think about talking more about that, the natural versus changing expectations? What else do you think is going on there? Is that applied to everybody? That applied to different cultures based on your experience?
I mean, I think one of the reasons is that, patients are not prepared, like, they don't get attention for the illnesses for the, like 80% of the course of the disease, and just during when they're very sick and dying, they start having this, treatment and stuff. So it's, even the patients are not prepared for this, I guess, the severity of illness.
So if you are knowing your assumption that people are not prepared, what happened when they were naturally dying at home, and where we dropped the ball that now people are not prepared to die when our ancestors, I'm Colombian, I'm not American. I mean, I'm American, but you see what I mean. People died. That is part of who we are in my culture. Here somehow, in some point in history, something based on what Chaplain Brown is saying, we dropped that natural course. How did that happen? Where did we that prepare to death disappear?
Well, I think what I was missing in this article was, are these, the patient is being asked to be admitted to a more, a medical environment, or, because I see usually the caregiver after the death, because I do the bereavement support, and in 99% of my clients, it's the caregiver who is not prepared. It's harder than you think to watch someone you love die, and it's sort of, they all talk about it's sort of a double-edged sword, because you want to respect their wishes, but at the same time, they're not medical, they don't know, now am I supposed to do something at this point, or is this part of the process? So maybe part of it would be educating the caregiver as to, here's what to expect, and some of this is not going to be pretty, and it's going to be difficult, but, does that make sense?
Yeah, you are moving to the next question, so hold that thought
Okay.
there, because it's awesome. Let us explore. I really like that we talk a little bit about that. People before used to die in their 50s, then we went to 60s, then now it's 77.6, women a little bit older. And because people used to die before, this caregiver role wasn't that big, right? Well, you die young, I did caregiver for you. With these life treatment saving things that we do, people live so long that now people are finding, oh, I'm a caregiver. So I think that you're bringing another piece of the complexity, which is, this is not only about the patient, and the study, and correct me, Dr. Espinosa, the issue wasn't, they couldn't look into patient preferences because these are fee-for-service billings. So they stated, we cannot tell you about preferences because that wasn't something that was there. But that's huge for the next question. But let us explore a few more minutes around that, 5 more minutes, and this great discussion. So I have here a lot of things about, there is some denial, there is some component of what natural means versus medicalizing death. We're talking about roles of caregiver that are new for society that before we didn't have. We talk about expectations, the miracle, the medicalizing that you are better going to be off if you are in a hospital than if you let the disease. What else in all of this journey do you think?
Well, Dr. Novak mentioned the litigation.
Yeah, I'm sorry. Let us talk about that.
well,
Oh, he left.
and then you go back to the cultural part of it again, because we didn't touch on that
Please,
enough, I don't
please.
think either. In the United States, and maybe some other westernized countries, there's so much available. My hairdresser is from Mexico, right? And her whole family lives in Mexico, and her father had liver disease, and they don't have liver transplantation. And so for her, it was, well, he can't get a transplant, it's not available, so instead, the family gathers around the man at home. And he wasn't old, he was in his 50s. And then he dies at home with his family because the treatment isn't available, which made me think about, okay, transplantation, liver transplantation, cost-benefit analysis, there's a lot of downside when we do transplantations. There's no guarantee. But I think that because that option is available in this country, we think that we're guaranteed a positive result. Not just that it's an option, that it should work.
Do you think that it should be a right?
Well, it seems like that's the way it's interpreted,
If
like,
I
well,
can't pay for it.
Can you talk more about that?
Well, I see technology as if we have the ability to control that, then why not use these tools? Why not start throwing, and if it's the medical team or the family, I mean, both can be guilty of it. We don't want to, if we have technology, we want to use it, I think.
yeah.
And it's that controlling, or almost as in American culture, it's a right.
Fabulous concept. I am so amazed when I moved to this country. Everything is a right here.
Yeah.
Like, oh, everybody else rights? No, it's my right. But hey, rights are this very complex issue of societies and things. So what do you guys think about that? That's a great perspective, rights.
Actually, I have like a personal experience. My own uncle, my father's brother, was diagnosed with an autoimmune hepatitis, developed cirrhosis. So, we never were aware of this diagnosis until it was too late. It was diagnosed when he, had developed cirrhosis. Just last year in November, he was diagnosed.
Where?
In India.
In India, okay. I just wanted that. Setting is a huge issue. So India, okay.
So, and my dad, we have a long family of doctors, and so, his prognosis was 6 months or less, right in November, he was already having ascites and GI bleed and everything. So, so we knew, even though, we had the money and everything in India, manpower, we could have done a liver transplant if we wanted to, and, but then, we think that this is something which is not going to get any better, and chances of him surviving the transplant or even having a successful result are minimal. So, he actually passed away, in April. But yeah, so like we all, sat together, like my dad and his family, and we made him comfortable, and, so he was at home, he died peacefully at home.
So I wanted to ask you something. Do you mind to share personal stuff if I put you on the spot? Okay. So what about in a biculture where, how you handle pressures? Did you ever feel that you are a family that could afford that? Will that being seen as you didn't pursue a right and that was a failure? How you handle that being now bicultural? How your family went through? Did you get somebody from the United States, family member saying, hey, but we can't afford to bring him here? Are you bad? How you're going to dare to let him die? How you navigated that, and did you find that that was an issue with your story?
It was an issue initially because his daughter, lives in California, and so like she was of the kind that okay, why can't we do this? Why don't we do this? We can go ahead and do the transplant, and let's see how things goes. And so then then at that point, my dad he's also a surgeon, so he actually sat down with them along with the primary physician, and then they told them that it is not going to be of any use. Just wasting money is not what we want. And so she was able to be convinced. It was not like a very overdrawn discussion or argument about that.
So it sounds like a lot of education. You did a family meeting led by a surgeon, which is awesome. And somehow the prognosis helped. Hey, don't waste the money. What he would have said, well, we don't know. We maybe could try it, and he maybe had a chance. Do you think that that would have changed?
No.
You don't think so? Why? I'm just curious.
So it would have changed the prognosis?
Well, it would have changed your decision making when there is doubt which many of these cases that we discover and reading these articles, sometimes there is a little bit of, there is not a clear answer. Well, when it's yes or no, it's easy. They're dying regardless, I think, well, but when it's like, I don't know, I have been in those circumstances where I don't know. Do you think that, what else would have modified in your culture or your decision making to choose a different thing?
Usually, in our culture, like, my dad is the eldest brother. So, everybody respects him, looks up to him. So, and like, both my uncle's kids are not from the medical field. So, they were really, looking up to my dad for some answers and, right answers in this case. So, even though they wanted him to get a transplant, they did not, my dad was able to convince them and, make them see the real
Other
sides,
sides of
yeah,
the
and,
issue.
understand
Okay.
the story.
Well, that moves us to the next question for open discussion. All of you, the majority, are graduating in a week and a half. And you're going to go and get a job somewhere. Some of you will stay here. Some of you are moving. Some of you maybe are graduating in the next couple of months. I'm saying you're graduating pretty soon. And this data is what is going to be in the minds of your CFOs, your nursing staff. And you're going to be graduating with a title of expertise. You're going to be a geriatrician. You're going to be a palliative care name. Physician, palliative care chaplain, palliative social worker, palliative nurse. And you have learned all of these things and you're facing a change and the opportunity for the first time to make a difference. How you're going to approach that? What kind of things do you think you would like to start doing? And what do you think will be your challenges? Or you think that people saying, I have seen it all. I'm a palliative care chaplain. A palliative who? And the McAllen area, I'm a palliative care board certified geriatrician. Well, we more or less guess the geriatric part, but where the palliative is, this is coming from people that have graduated. And you can just not show up without some sort of a skill. So what are some thoughts there about you making a change based on all of these horrible data? Oh, it's not that horrible, actually it has some.
I don't know, increased use of hospice services, also ICU and transitions. I don't know, not that great.
Not that great, so.
There's good and bad.
So how are we going to do that?
Educate.
Yeah, that's what came to my mind.
Okay, educate, so I more specific.
Educate the physicians or healthcare givers. It's like, I feel that patient doesn't need the surgery, is not qualified, he doesn't meet the criteria for surgery, but he still gets it because there's a surgeon ready to do it.
And
Like the
it's-
transplant,
So I'm playing here moderator. Great idea, I'm going to play the other side. You're going to educate me when we believe in a miracle culture, when we have high litigation, where we have all of these caregiver barriers, where we are medicalizing. How you plan to do that?
Because
No, it's up to you. It's open for discussion. Guys, this is what you get. You get in your hospital,
Yeah.
and you came with what they call in Harvard the wet dog syndrome. Any of you have dogs? So when the dog gets wet, what the dog does by reflex? He shakes. And what do you do when your dog shakes? Well, you are going to behave like the wet dog. You are full of energy, you have all of these, conquered the world, and then you start shaking and everybody in the hospital is, oh. So when we do faculty development there in Harvard, they tell us, be aware of the wet dog syndrome. And I'm not wanting to be, but we need to understand that. That's the reason the opening question was like, we have a set of challenges that you need to be aware. So education is fabulous, but how we will advise, coming from faculty, these young professionals that are just ready to enter, what are some practical strategies? And again, if somebody else from your own class or other discipline, how you will avoid the wet dog syndrome?
including palliative in the patient's care right from the beginning. Like patients don't even know what, palliative care is. And then, when we go and introduce them, introduce ourselves, they don't know what that is. And then some of them who do know, they say, oh, isn't this what, you do with hospice? Like,
Step above.
yeah,
Just
so,
one step.
this is like the stuff about hospice, or like, aren't you the one who sends the patient home to die, or, so, the whole impression is so wrong. So,
So start one-to-one, explaining that to the patient. Are you joining teams where palliative care is already running, or you guys will be the first ones carrying the flag? You don't know, probably, or you do? I mean, I don't know, you guys don't know yet where life will land you? No yet? No?
Hopefully it will be established.
Well, so you will say, in my checklist, let me join a program. But what you will find in what we were discussing with Dr. Espinosa is we need a huge need of you being carrying the flag for the first time. And the majority of you will be carrying it in places where they maybe have a palliative care, but I can tell you, nursing homes, gigantic need to geriatrics and palliative care. Good geriatrics. See older people, or being when somebody died doesn't mean you're providing good care, right? And that's what we get in geriatrics. Oh, I see old people. I'm an expert in geriatrics. Well, actually, no. Let me see the outcomes. You see people dying. It doesn't mean that they die appropriately. So one of the things, approach your own, how you do your elevator talk to the patient, your elevator talk to that institution, to that nursing home, to that home health, to whatever you go. What else?
Along the lines of education, I think we talked about the culture of death within our, let's say we get our idea of what death should be or is a lot from media. I think maybe it doesn't give us a good way to do it. I wrote down, we're not prepared for death, because I don't think our society and culture isn't preparing us adequately. So I think part of the voice of palliative would be another education steps. And I remember recently in a family meeting, we were dealing with the patient, we were talking about the patient and trying to figure out how is this going to look like, and is this acceptable in what we're doing? Is this the kind of death that they want to see, or is this what, they're motivated to care for the patient, and can we deliver? Can we help them reach that goal? So educating what a good death would look like, I think is high on the list.
I think that goes back to something that I was thinking, like what you said, what are you going to fall back on, or what's your strategies? And I think you bring that out by, for me, it's always falling back to patient preferences. What does the patient want? Because you may want to do your surgery, but the patient doesn't really want to go through another surgery. But sometimes they don't even know if they want to go through it or not, because they're saying, well, this doctor's saying that I have to do that. I have many examples I could spend where the patient is asking me, what am I supposed to do? I had a patient who, a GI doc in the community is telling him he needs a PEG tube because it's going to reduce aspiration pneumonia. And I'm like, oh my God. And there's a lot of misconception out there. And I'm not saying we need to convince the patients of anything, but we need to educate them. Me just telling him that's not true. If that's your only reason for doing it, that's not true. He was like, no one's ever told me that before. But if the patient seriously said to me, I really want the PEG tube, I mean, even though I don't think it would be a good option, I wouldn't force my wishes, obviously, on him. But I mean, they just need someone knowledgeable in geriatrics and palliative care to help educate. I think that's basically where you're going. They don't know what death looks like. They don't know the pros and cons of these various procedures that are being offered. They're looking for guidance, but unfortunately, because of the few numbers of us out there, there aren't really people there to give the appropriate guidance. Not to toot our own horns, but we're not too bad, right?
Exactly. And not even at different levels. What the primary care community needs to learn and update, what the multi-specialty community will need to update in terms of appropriate therapies or not. So finding ways to be part of committees in your institutions, delivering run rounds in your institutions, be in the patient safety committees, be in the pharmaceutical and therapeutics committees, being in the patient satisfaction committee. These days there are committees for everything where I think the invitation is all of you should be not only seeing the patient one by one, but can you be enrolled in a leadership position where you could shine when somebody is struggling, you could say, well, I actually have a skill on this, I could help with this. From any discipline. And that's what we're trying to do in the hospital and the communities is having people from multiple disciplines enrolled. So I think that's what we're saying, can you also make good collaborations? Maybe it could be with the ambulatory clinics, with other primary care doctors if you work in the private sector. Working with the hospitalists, that's what we do in the ACE unit, making recommendations constantly, and little by little you change the culture. Bringing national initiatives to the hospitals, right, that will care for better older adults from nursing with the NICHE program, national health initiatives for the elder care, healthcare systems, and models and chaplaincy, nobody dies alone. I mean, so I think it's important that we see in the big picture that this is not going to be easy, but it's awesome. For the first time in the healthcare, these two disciplines have a tremendous impact because we're the ones that know how things can be transformed. So people are looking for the expertise to do that.
The thing is, I think that like these discussions will affect you or any surgery. I mean, patients have little knowledge and they probably won't ask so many questions and they will just follow the physician. So I guess, I mean, as a palliative care physician, we should be involved in this discussion. Be like a, impartial, witness during this conversation. I mean, I see a neurosurgeon come do a like craniotomy, take blood, and go back to me, and then he's done. I mean, after that, trach and peg is a different physician, like an ENT physician, and he's done. He does the trach and peg, and then it goes to medicine doctor, and he does the acute management, and he's done, and he goes to a nursing home. So it's like,
And no one's
there's no
looking at
one
the
that's
big
there
picture.
for each decision.
Yeah.
There's not a
What
common
are we
person
doing?
helping them.
Yeah.
And then the neurosurgeon doesn't think about patient ending up in like nursing home. He is only thinking about his thing, just doing it, and he's done after that. So when he's having his conversation, he will be like, oh, this patient is dying, I have to take this blood out, or else he will die. But he will not talk about, I take the blood out, but he will end up in nursing home. That's not his conversation. So when I mean, if as a palliative care physician, I might be involved in this conversation, and then probably, because I know what's going to happen, I might give like different pictures to the patient and the family to decide.
And I think that's important, is the relationship that you will build with your other colleagues, the respect, the availability that is going to hopefully build over and over the same message if it's consistent, which is, have you thought about what will happen with this person afterwards? And make it relevant to them. If you don't think about that, this patient will return, and your readmission rate will look bad. So it's good to talk about social history when you have a neurosurgical patient. It's good to talk about family preferences, or the patient can return. So somehow finding the language that the system is using, that for the first time is actually looking into quality. Before it was just encounter and you do what you need to do, charge the system. So being knowledgeable about that. Let us talk a little bit about the ICU issue that was big in this area. So high utilization, not only on hospital services, but specifically ICU. So what are your thoughts? What have you learned? What do you think you will be facing, and what have you wanted to approach that?
People panic
Okay.
when something goes wrong, and the first thing they think of is call an ambulance.
Yeah, I mean,
And you end up back in
I
an
mean,
ICU.
having us in ER helps. I mean, I've seen patients come to the ER from hospice, and they come for like pneumonia, respiratory distress. We would speak to the family and say, these are things that we can do, and then we can do this at home rather than them coming to ICU.
So very early intervention on the ERs. That's what I'm hearing, right?
Mhm.
We have something called Mobilize, which is acute care of elderly mobilized. So you bypass the ER or address the issue there. So being present when the crisis, that's what I'm hearing. Sometimes can help, right? Versus, hey, there is a consult, your patient is already intubated. So
Yeah, because put yourself in the ED doc's position. He doesn't know how to talk to. Well, I shouldn't say that, but I mean, he's like someone who's critically ill, ICU, but he doesn't have that expertise to say, we don't really need to do that. And so, in my experience, I think that those providers in the ED would be very happy to have our assistance to help us out, because truthfully, I think, I mean, I used to rotate in the ED a lot. You're just trying to manage all of that, and I would never, I mean, that's a tough job. I would never want to have it. But, so yeah, being there in the time of the crisis. Or, as you said, educating the family before the crisis.
Exactly.
This is what's gonna happen, and don't freak out,
they
call
don't
me.
Exactly.
Or
bring
call
the
whoever
issue-
they're supposed to call.
Which
Yeah.
brings the issue of the number of hospices. Do you remember the data? They have grown exponentially. I mean, they went from, like in 10 years, from 2,000 hospices to, I don't remember in the
Oh, I
article.
don't remember.
But I have found in my practice that not all hospices are equally.
Well, that's
Is that
true
your
too.
experience?
That's
Yeah,
true,
I mean, the
yes.
crisis care and the, like, IPU, most of them don't have it, and they're sharing a nursing home thing. And then, like, if there's a crisis, the nurse goes like in an hour or an hour and a half. Because the payment for the crisis care, like 24/7 crisis care, is so less, they don't want to keep a staff there at the patient bedside. So they rather wait for the family to call and then send it. So, but the family doesn't want to wait for an hour to wait for the nurse to come and do the crisis care. They would just call 911 and take it.
It's a pretty good explanation for what they don't know in the article why people are using the GIP services so much, which at the end of the day, you do the math, it's probably even more expensive than keeping them in the hospital. So can somebody explain for the non-MD and people that do not understand what the GIP service is?
So, I mean, if there are certain symptoms that needs monitoring and frequent administration of medication, then you can take them to a facility where there will be a nursing and aid care 24/7. So it's usually, in a special setting, like, or they can share a bed in the hospital or a nursing home. So if the patient has like a symptom like that cannot be managed at bedside at home, they'll bring them to these facilities and do it. And then they can do like, IV sub-Q administration, they have more access to medication and easier access to medication than at home. At home is usually PO medication. So
And it's usually very short, it's a
Right.
crisis care call, it's up to 5 days, and sometimes it's very expensive per day, but the Medicare benefit pays for that. So what they were finding, these Medicare beneficiaries, is these people were using that service, so if you equally keep them at the hospital to get the symptom, it defeats the purpose of decreasing healthcare utilization. So again, that's data. So we were talking about more education, more partnership with the hospices that you will be working with, your geriatrician or palliative. Those are the things that we do in transitions of care. What else?
Having an out-of-hospital DNR. And, I had a patient not too long ago, she was a DNR denied, but, she fell and she passed out, and she was not breathing right. So the son called EMS. The son could not find the out-of-hospital DNR to show the EMS at that time. So she was intubated and she was brought here.
So most of the times I tell them to like tape it to the refrigerator or put it somewhere really important, but yeah, that's really too bad.
That brings the whole issue of more preparation, advanced care planning, working with the caregiver, exploring what natural death and progression of diseases and all of those. This article didn't talk about, because we have just 20 minutes left, changes with the Medicare managed care versus Medicare fee-for-service. This was pure fee-for-service. Do you know the difference? So we can, if you don't know the difference, we probably can know more. Do you mind to share what your understanding is between one and the other?
I'm sorry.
Medicare fee-for-service versus Medicare managed care.
No, I don't.
Okay. This is very important for you guys because Medicare traditionally had the fee-for-service developed, as an acute care visit. In those days, it was developed for acute crisis, no chronic disease model management. So our Medicare pays for everything that acutely you get sick. You get a pneumonia, you treat the pneumonia. If you get a CHF exacerbation, you create CHF exacerbation. When people start living longer, the consumption of the resource became from acute model to, well, these people relapse, but I'm paying every time they get sick. So the model wasn't designed for chronic disease management. Over time, when managed healthcare organizations came, they said, if you give me a set of elders that I can enroll, I will offer them extra services, a very intense case management process, and I'm going to keep this population as healthy as I can with a set of money. You give me a lump sum of money for these beneficiaries. And those models have shown some benefits. They have very aggressive case management in the ambulatory setting, and more than ever with the accountable health organizations. They are really integrating with, I don't want it to choose just 20, 30 hospices. I'm going to work with these 10 that I know have programs in place, communication with my case manager, so these people don't end up in the ER, which is your ideal model, right? The fee-for-service doesn't have that. They just, Medicare beneficiary enrolls and that's it. There is also controversial data where patient satisfaction is equally going both of them. You go figure, I don't understand the data. Medicare managed care usually offers you dental care, glasses, transportation, things that your fee-for-service, forget it. That is something that I don't know you're going to be working in, but you need to know those differences in healthcare. Because my guess is in the future, we are going to adopt more and more in our models that are integrated. That you get more aggressive case management, the continuous of care. And I will give you an example. WellMed, my neighbor was enrolled in WellMed. He went to see the geriatrician. I switched primary care. He needed a geriatrician, so he went and saw a geriatrician, and he got the right diagnosis. He got moderate Alzheimer's dementia, trajectory of declining, was likely going to die. In 48 hours, a hospice team, case manager, came and had a meeting with the family without any commitment about what hospice could do. Now, of course, I already have been talking with my neighbor, so it makes it very easy, a lot of caregiver burden. But if you have a fee-for-service model, things is the physician would have initiated the hospice visit and wait until the family make the mind, and then you will do the follow-up, which could fall to the crack. I was very impressed with that, and they were calling and being sure that he got everything he needed through the hospice of their choice. They didn't choose their hospice, but also being sure that the primary care in this case didn't manage the patient anymore. It became a full care for the hospice, so there were no duplication, no more like happened here. They come from the nursing home and they're in hospice, and then suddenly you have 3 physicians and you don't know what to do with those. So any of you potentially will explore a managed care position.
So that is the Advantage plan, right? That's
So you
the
have Advantage plan,
right? That's-
ARP, you have
And we have the
WellMed, you
WellMed.
have Aetna, you have Blue Cross Blue
United
Shield,
Health
you have
Group,
United Health. There are around
okay.
47
So those
programs
are-
in Texas.
And those are the managed care plans, okay? Because
Yes.
people are scared about those, but I guess because they don't understand them. Even I myself don't understand all of what they offer, but the education needs to be there then. And as a public health nurse, we see seniors in the community all the time, and that's one role that I guess I have to play a bigger role in, students and nurses, to educate them about the differences and the hospice piece and what hospice is, the importance of getting hospice early rather than wait until the
If
end.
I am correct, we have in the medical legal conference, I suggested Dr. Rapier or somebody, so attend that conference because they are going to talk about managed care role in the healthcare reform. So keep posted, that's another thing. They're complex and there are some better than others. I also can tell you that they are so aggressive in decreasing some services
Yeah.
that if you wanted to skill somebody under the fee-for-service, you can skill them longer. With managed care, they will give you less time. So again, there are patients that model maybe won't fit their needs, but I can tell you with healthcare reform and paying for quality, we need to think about cost, utilization of resources, more aggressive case management. We need to think in the terms of what they are doing. Very aggressive in understanding what patients benefit from more chronic disease management, which ones we need to move to palliative care trajectories. So that's where, again, your expertise will be vital, leading to really to get to know.
It's a health policy issue also.
It's a policy issue, so
Health
explore
policy.
that. What from your public health perspective, what do you think?
So that's something that we have, physicians and nurses and other healthcare providers need to make a bigger case in Washington we need to talk to our congressmen and the, our state representatives and let them know this is really what's happening, because they don't understand either. So we are the ones that need to talk to them more and get the policies passed in Washington and Austin. That's where.
And I think that that's another real well taken in terms of all of these changes in utilization. And right now, for example, there is not a big payment if you keep people healthy. There is not a reimbursement for that. President Obama passed in 2011, January 2012, I'm sorry, for the first time, a preventive health exam for Medicare beneficiaries. So for the first time, we were getting paid
Right.
to do the right thing. And the exam is about wellness, so you don't need to do a physical exam. It's just talking about your diet, your exercise, physical activity,
Your screenings.
medication use or screening. So again, utilizing that a little bit more, yes.
When you talk about the managed care, so they can elect to either have straight Medicare A and B,
Yes, ma'am.
but then do they pay more money? Like, don't they have to pay more money to have a managed care plan?
Not
So it's
necessarily. The managed care is intended to supplement services
Okay.
by keeping you healthy. So in other words, it's not much more expensive or not. It's just you are going to utilize more preventive services with the idea that I will save money on you. So again, not everybody qualifies to that either, and that's beyond my expertise, and I do
It's
not.
very complicated.
It's a little bit, but you see RP very aggressively, for example, said if you are diabetic, we will take care of all of these supplies that sometimes with your regular Medicare you want. So they target to chronic disease management, and their models of getting some of those managed care are outstanding. They have better hemoglobin A1Cs because again, they have other components that fee-for-service doesn't do. So that's important, and I think the idea to these hot topics is you need to become politically active to fight for your seniors, like anti-SS, but you also need to learn about how Medicare plays, because some of you are going to leave the VA. And if you're going to go in, like in the 30 years ago, you just see patients or do consultations, you need to be very knowledgeable.
So how does all of that impact VA? Is that where our medical home and PACT teams and whatnot are coming from?
I think Dr. Musi can speak more, and Sandra, but the VA has one of the biggest geriatrics leading programs in the country, piloting national initiatives for healthcare. Does it look a little bit different from the community sometimes? I think the resource allocation is a little bit better here. So give you an example, in home primary care, you have an elder that has catatonia. He needed to be picked up from the bed to the bathtub, and he got a railing that cost the system $10,000. Can you get that in the community? If you pay privately. The VA actually will honor that for elder veterans that will do it. So when I saw that, I was like, wow, only the VA will do that.
So all of the clinical programs at the VA are paid for by VA, but some, if patients have supplemental insurance or Medicare, they can also charge for those services as well. And but for example, like all of the additional service, like we have the home-based primary care, they have a pharmacist, they have a social worker, dietitian. I mean, they can charge a supplemental insurance and Medicare for those services, but those are positions paid for from VA money, really. Dr. Musi might be able to explain that better, but the idea with the VA is it sort of is like a managed care, capitated care system. I mean, we have all these veterans in our South Texas Veterans Healthcare System that we have to take care of, and they're always thinking of ways to save money. So hey, if we have a palliative care consult service, then perhaps that saves money. And like one major initiative is to reduce 30-day readmissions because the hospital doesn't get paid for that admission. And that takes up a bit of an admission that they could get paid for. Plus it's kind of an indicator of poor quality that a person had to get admitted within 30 days for the same diagnosis. So the VA is really, I would say, one of the leading in the geriatrics areas. It has very, they actually provide funds where people can apply for, which we have, to develop new programs to not only cost save, but also improve the quality of care, so.
And I think that's important in terms of documentation. You guys, every time that you have a service, the VA value the interprofessional team members and the physicians, document, do your telehealth, your note. It's good patient care, but at the same time, that also is looking into models to trying to integrate services so it's available in a higher level. If you could possibly do, I think the future will be that, how we can integrate what the other professions do and give them a value unit for it. And again, Medicare, like Auntie says, they don't know how to do that, so the Center for Medical Innovation Center since 2008 is looking for any pilot project that brings teams together that will decrease the cost in some area. And now, again, the VA remains unique in certain areas.
Yeah,
but
I mean, you guys will get, when you get out of your fellowship, you'll see this, but the VA, in my opinion, although it has its issues, you know, with things, certain things don't always run as smoothly as they could, but you have so many of these other services available in the real world, it's not so wonderful like that. I did my fellowship not in the VA system. In our clinic, we did not have a social worker, we didn't have a dietitian, we didn't have any of that. So I think we're a little bit spoiled in some ways at the VA, and that's why I love being here. But like, for example, in my fellowship, we had a house call program similar. I mean, the idea is that it's home-based primary care. Well, it was the fellow. It was me. I was the house call program. But look at what we have here at home-based primary care. There's like probably dozens of people working in that program for, what, 200-300 patients? I don't know how many they have. But I mean, just the resources available are so wonderful. But you may get out in the real world, so to speak, and not have those resources. But if you know the value that it can provide and the potential cost savings, you may be able to advocate to get, I need a social worker really badly or whatever. Yeah.
And that moves us to our last question for our hot topic, which is transitions perfectly. What specific models of care are you familiar with that you work this year or you will maybe join an institution that are producing good cost-effective care?
IDT, I mean, I think that, you know, I've never seen an IDT like this over here.
The interdisciplinary team. So working in teams, how, be more specific, Chika.
So, I mean, you know, the teams include, you know, especially at the, you know, at our consult service, the chaplain, social worker, nurse, then the pharmacist, physician, and, you know, and the psychologist. So this actually, you know, gives total care for the patient and the patient's family. And so right from the, you know, start that the patient comes into the hospital and, you know, up until the time that the patient is discharged to go home or, you know, wherever.
So
we work together.
High functioning teams that can work in different settings, that communicate continuously. Very good. What else?
All my training has been in the VA, and I don't come from a military family. So now my parents are in their 70s, and trying to find a way to get them the same kind of stuff that I know we have here is impossible. It's impossible. Cannot figure out how to access resources.
So in your ideal world, how that will look?
Well, it would seem that there needs to be like a clinic, interprofessional clinic model in the community where when the person comes in, they don't have to go like, okay, I just went to my primary care physician here, but now because I have osteoporosis, I have to go to my doctor, bone person. And because I also have a heart condition, now I have to go to my cardiologist over here. I mean, the old people spend huge amounts of time driving to the doctor's office, sitting in the waiting room, rather than having, you know, that little like one-stop shopping sort of a model that encompasses everything, not just their medical stuff, but we were talking about the like grab bars and other OT, PT kind of things have a social worker or somebody that can go do a home analysis and assess for safety and make recommendations for how they can stay at home for as long as possible. I don't know where that is in the community.
So I think that you're bringing a great point of what the future is desired from Medicare. What Chaplain Brown just mentioned is what Medicare is intended, more integration of services, more interprofessional care, one shop that can fit the needs of patients, less transitions of care because you have all of that. So the good news is if you ever decided to retire, that's a great thing to bring to the community sector and say do it. I know there are, our group is attempting to do that to the geriatric clinic at the Market and UT Senior in Christus, integrating less physicians, direct admission to the ACE unit, communication with the long-term care, and there are a lot of primary care that we can do that you don't need to refer. But not in the level that you have, that you want to see, because right now the system is gently, slowly moving to quality. Hopefully in 10, 15 years we will see more clinics where the pharmacy gets paid, where the social worker is on site. Right now, unless the hospital fund those positions, is a lose-lose proposition. But I think what you are looking into is where the country is moving with healthcare reform with that. So that's a great model of care.
The Alamo Service Connection, that is part of the Bear AAA agency. They saw the need for the community, more coordination in the community. So they've got a central call station where you can call in, and then they refer you out to all the different social services and resources in the community. But they don't really have a clinic. It's not a clinic, it's an outpatient. I mean, it's a community referral source, that's all it is. So, but they do get money from the federal government that comes to the Alamo Area Council on Governments, and then they distribute the money out for these things like transportation and other little things, especially for the needy. It's mostly for the needy folks. So if you have a certain income, then you have to pay out of pocket.
That's true,
But-
there are resources.
It's
Yeah.
get to know.
Yeah.
Right?
Yeah.
So I think
The
that
area
that's something that we're going to try to put in our
agents,
curriculum.
Council
The
on
Alamo
Aging.
ACOG.
ACOG.
Yes,
Yeah, they do have a lot of resources.
they have resources, and I'm working with them in the summer because we're going to do a program for the seniors in the community on how to prevent heat injury, heat exhaustion, dehydration. And that's going to be a partnership with the school and with them and with the city of San Antonio. But
And I think that the last pearl before we close, Chica's Clinic, and I have a talk downstairs, so we need to go, but get to know where you go, what is available. My fellows go and do field trips. I don't bring speakers anymore. I send them out to go to places where when they refer now, they have a mental picture of what they do. So maybe encourage your fellows, your disciplines, to go out and visit places and get to know what is available or not and work with projects. And so we're going to make some changes in curriculum on that. With that note, we wanted to say thank you for coming. I hope that you enjoy. It was kind of an interesting, provocative discussion. Our next speaker is Dr. Arlan Richardson in August, and he will be talking about rapamycin. Should we really extend the life of people? When do we stop? What is going to happen with the planet when nobody dies because of him? So, please be on target with that one, and we'll see you in a couple of months for hot topics on geriatrics, and thank you for coming.
we have death panels for the older folks.
Oh, we
have
need
death
death panel,
panels.
don't say death panel.
That's
Yeah,
what we do.
right, yeah, we did it fine.
That's what they think, is that what they think?
Estudié medicina en la nacional.
So the famous saying in life certainly green is just good recycling.
Solid green,
Yeah, you see that with beer.
I saw pieces of it. So that's about, yeah. Need of space.
Mira, yo voy a reunirme con Leo. Es que es colombiano. Sí, es paisano. I didn't know that's awesome. I'm going to be with your faculty because I'm going to share with your reactions para que vengan los lunes. Tenemos